Okay, guys. So this video is going to have some different components in it between our drawing, textbook, PowerPoint, things like that. And I'm going to switch between them. So bear with me when I'm switching between pieces of information that may be not as visually appealing, but I will fix it as soon as I can. That being said, I know I stressed it yesterday. I'm going to stress it again. The importance of the anatomy and physiology of the cardiovascular system is imperative to your success overall. And I don't mean that to say that there's 15 test questions that say blood moves from the right atrium through what into the left ventricle or to the right ventricle. And then that's not what I'm saying. But what I am saying is that if you don't understand these concepts that I'm explaining to you right now, and you don't have this as we progress, you will have trouble and not be able to be really successful, because we're talking about some of these basic concepts right this minute. But in the next set of chapters, we're going to talk about how all these valves that you're identifying, like the tricuspid, pulmonic, mitral, and aortic, these valves that we're talking about, how each one of them impacts a person's health. If one of them is altered, what the sounds you're going to hear are, and where that blood flow is going to be redirected, and how you're going to see that in signs and symptoms in the patient. And so this is 100% something that you have to get now to be able to continue progression through the course and have a good grasp of this, to be able to understand things in the future. So that's why we've talked about it so much, and we're just going to kind of briefly go over that again. This is the heart in the box that we kind of drew yesterday. It's very basic. You do have this heart here in your textbook. It's going to give you very similar information with a little less, a little bit more detail, maybe a little less concise. So it may overwhelm you a little bit initially, but start with the heart in a box and then move to this. But it's very, very important as we're looking at this that we talk about all these components and kind of how things work. So that inferior vena cava and superior vena cava are dumping in to the right atrium through that sinus, that atrial sinus. That blood is then being ejected from the right atrium through the tricuspid valve into the right ventricle, and that valve is held in kind of to place, if you will, by these little components here, the chordae tendineae, that go all the way down to the base of the ventricle into that muscle layer. So when that muscle contracts or pulls down that valve, it opens up, allowing that blood to move through. And then when it squeezes, it puts force on it, closing the valve, so that as the blood is being pushed out of here and up into the pulmonary arteries, nothing will back up there. So as this squeezes, the valve closes. And when that closes, that's when we hear S1. That's that first heart sound, that lub right there, as that closes. While that's happening on the right, simultaneously on the left ventricle is ejecting blood out to the aorta. This mitral valve is closing, and that is also creating a simultaneous sound, S1. That's what you're hearing. So that blood has been ejected. It's gone up through that pulmonary artery into each of the lungs that are over here. That gas exchange is occurring in those lungs. It's picking up that fresh oxygen, dropping off that CO2 so that it can be expelled through respiration. Once that exchange has occurred, it's going to be coming back in through these veins, these pulmonary veins here. And those veins are running all the way through the back side of the heart where we can't see it, and dumping into the left atrium, and coming in from the left side and dumping into the left atrium. That's being then ejected through that contraction of the atrial muscle through the mitral valve into the left ventricle, same exact process. These chordae tendineae here are pulling, allowing that valve to open and close. And in that process, the blood is then ejected. It goes up through the aorta, through the aortic arch, and all the way back down to the abdominal aorta down here. This would be abdominal aorta. And from here, we've got these primary pieces coming off. These are going to go up to the head. Here's our carotid artery. This is the brachiocephalic artery going up into those upper extremities, and the subclavian artery. Clavian meaning clavicle. So right here under the clavicle bone is where this artery is coming through. So these are coming out and feeding the upper half, and it continues down that arch, just as I said, goes all the way down through the aorta into the abdominal aorta. It's going to fork off into your renal arteries, and then have all these other components where it sends blood throughout the body. So that circulatory process is an ongoing process. When these are when the ventricles are squeezing and pumping the blood out through there, this valve is closed and it's opening this valve. I'm going to clear this off so we can see a little bit. So when this valve here is closed, because the ventricle is pushing blood out through here, these valves are going to be open, and these valves again are going to be what? Our pulmonic and aortic valves. And so when these are closed, these are open, and then when these close, that produces that S2 sound from the pulmonic and aortic valve, and these are open as the blood's moving from the atria into the ventricle. So please, please, please familiarize yourself with that. Make sure that you really have that understanding there, and then make sure that you understand how those components work so that you can use that moving forward, okay? So let me clear this. And I'm going to pause for just a second while I get the book to the next image I want to look at. All right, so we've looked at the anatomy of the heart based on the vasculature or the blood supply, but then the secondary component of the heart that's so important is the electrical conduction system, and that's going to start here with the SA node. The SA node is our pacemaker. Our pacemaker is firing at about 75 beats as an average. Our normal range is 60 to 100 beats per minute. That signal is traveling down across the atria to the AV node and across the left atrium as well, so that both of them are contracting at the same time. That signal, after it's traveled across there and down into the AV node, is going to travel from the AV node into the bundle of His, down through the bundle branches, and then into the Purkinje fibers, which are going to go around the entire myocardium of the heart. Let me get a new color here. Red's a good color for muscle, right? So right here, this big thick portion, that is the myocardium. That is the actual muscle of the heart that we're referring to. This section here is the septum. That's what's dividing the ventricles apart, is the septum. But those Purkinje fibers are going all the way up through the entire musculature of the heart, sending that electrical impulse, making the muscles twitch. So if you've ever used a TENS unit, if you've seen someone tased by the police or with their friends, their muscles are squeezing up because of the strength of the electrical impulse. The signal that comes out from our heart is the exact amount needed to stimulate contraction under normal circumstances when our electrolytes are appropriately balanced. So SA node, that's the pacemaker, 60 to 100 beats per minute, averaging about 75, transmit to the AV node. If for some reason the SA node is malfunctioning and it is not sending the appropriate signal, the AV node will try to compensate for that. It's going to pick up at a little bit slower pace, usually about 40 to 60 beats per minute. That's going to then transmit that signal through the bundle of His to the bundle branch and into the Purkinje fibers to stimulate contraction of the ventricles. And if that continues to malfunction and all else fails, these fibers will make an attempt to do their own thing, but they're only going to function in that 20 to 30 or 35 beats per minute. system. They cannot maintain life like that, but they can at least stimulate the heart to contract enough to send some blood through there. All right, I'm going to pause again while I get the stuff reset. All right, so we've talked about cardiac output, and that cardiac output is heart rate times stroke volume. The stroke volume is the volume of blood that's being ejected, and then the heart rate is measuring how fast the heart is beating, that ventricle is pumping. And so with every beat of the heart, we put out about 60 to 80 milliliters of blood. And when we do that, that's 5 to 6 liters per minute. That's our total blood volume in our body that's circulated every minute from one end to the other. So the way we are going to evaluate how much of our blood is coming out from there is going to be through our EF, or ejection fraction. So the ejection fraction is going to be between 55 and 75% on a nice healthy heart, and that is how much of the blood that's in there is pushed out with each beat. So let's just pretend that this right here is our ventricle. Remember, it's kind of an oblong shape. And so we've got to look at how much of the blood comes out. And remember, the blood doesn't necessarily go down. It's kind of pushing up and out. And as that ventricle muscle down here squeezes, it's going to push out as much blood as it can. Some of it's going to go out through that exit portal, but some of it's going to kind of squish up here above it and things like that. So about what comes out is everything below this line, which comes out to be 55 to 70%. Okay. And that's a nice, healthy person. As a person's heart weakens, that ejection fraction will decrease, and that will decrease their cardiac output. The patient will end up feeling some signs and symptoms of that decreased output, like dizziness, lethargy. They're going to feel tired all the time, weakness, some of those type things. So what makes us speed up and slow down our heart rate to make our ejection fraction stay what it needs to be and our cardiac output stay what it needs to be to meet the demands of our body? And that is going to be our sympathetic and parasympathetic nervous system, and that's controlled by the medulla in the brain. So we get a signal from our brain that sends out based on chemoreceptors and baroreceptors in our body, sensing things that are changing. That signal leaves our brain and goes out and says on the sympathetic nervous system side that we need to accelerate our heart rate in response to a stimulus. Maybe it's exercise, maybe it's fear or anxiety, but there's a stimulus that is going to need to facilitate a change in the heart rate to meet the demands of the body. And so we're going to use the sympathetic nervous system. We're going to secrete norepinephrine, and the SA node is going to go, hurry up, go faster, and it's going to send those signals quicker and quicker, increasing our heart rate to meet the demands. In the exact opposition, maybe there's going to be other things going on, like our body tries to keep in check our blood pressure. We've talked about this, about how we try to compensate to maintain homeostasis all the time. Our bodies want to maintain that as normal baseline as we can. So like a rise in our blood pressure from something is going to tell our body, well, remember we did stroke volume times our heart rate is our cardiac output. And we always want to maintain that cardiac output. And so if all of a sudden the blood pressure is going up, that means our stroke volume is going to go up. And to maintain an equal amount of our cardiac output, we're going to want our heart rate to go down. So maybe we've taken on a whole lot of fluids. Maybe there's been a change in our body's demands. And so our kidneys are altering their function. Whatever is going on that's making our stroke volume increase, our body is going to send out a signal from the parasympathetic nervous system. And that's going to be usually acetylcholine, and that's going to tell our heart rate to slow down. The goal is to maintain the cardiac output. So remember, if the stroke volume's increasing, the heart rate's going down. If the heart rate's increasing, the stroke volume's going down if we're maintaining. If our maybe we don't have very much blood here and we want to maintain cardiac output, then both of them are going to try to increase the best they can. And so you'll see those changes. But that's going to tell us to slow down. Sometimes that's stimulated by the vagus nerve, sometimes that's going to be stimulated by the glossopharyngeal nerve. It depends on what is creating the need for change, but that's going to stimulate the release of acetylcholine and slow down the heart rate based on the demands of our body. Okay, so we talked a little bit about epinephrine. Release from the medulla, going to increase that heart rate. It's going to increase how hard the heart contracts to expel that blood, which is in turn going to increase cardiac output. And then also the blood pressure is going to rise as a result of that. We talked about aldosterone a good bit when you talked about endocrine, and we talked about that yesterday face-to-face as well. Aldosterone is excreted to regulate sodium-potassium. Sodium-potassium is absolutely pertinent to A, fluid volume status, B, electrical conductivity of the heart. So when that adrenal cortex releases that aldosterone, we're going to have a response based on the current body needs to either hold on to or excrete that sodium and potassium in order to increase or decrease the blood volume, which is going to increase or decrease our cardiac output depending on what we need at that moment. And then also to make sure that the conduction system is working appropriately to help keep that impulse in check the best we can. And then ANP. So ANP, atrial natriuretic peptide, it's going to be secreted from the atrium of the heart when it has too much volume and that atrium stretches or gets distended. As that muscle stretches and a little bit of damage occurs to that muscle, it's going to release that ANP, which is going to inhibit the secretion of aldosterone. And so with that inhibition of aldosterone, it's going to stop the reabsorption of sodium and force us to excrete more sodium. And since water follows sodium, our blood volume should decrease in response to stimulation of that atrium and stretching and enlarging and the increase in the ANP. So blood vessels, what are blood vessels? We have arteries. We know that arteries carry the blood away from the heart. They're going to be physically thicker and larger due to the pressure that they have to withstand from the force of the heart. We have veins. Veins are going to carry things to the heart. They have less musculature, less thickness, so they're going to be nice and thin and pliable. And they're going to be made up of valves that help to move the blood against gravity back to where it needs to be, almost like peristalsis through the guts. And then we have capillaries, which are very thin, maybe 1 to 2 cells thick. That way they can allow for the exchange of gas and oxygen, nutrients, waste products throughout the body system so that it can be put into the correct category for excretion from the body or sent back for respiration or whatever needs to occur there. So next image here, we have some imagery of the vessels themselves. We can see the extra thickness of the artery, which is indicated by red. We can see how stiff and thick that is. And then the difference here again is that valve. It's this component built into that endothelium or that inner lining of the vessel, which is keeping it nice and smooth and allows that movement of fluid through it, either by force coming from the heart or through that valvular movement going back to the heart. I'm just looking at my stuff, make sure I don't miss anything since we're having to do a follow-up. So blood pressure is created, as we talked about in the video this morning, about the force of blood against the vessel wall. We know that normal is 120 and diastolic Normal is 80. So we're not going to talk about that anymore because we discussed that extensively in the first video. The renin, angiotensin, aldosterone mechanism, you cover this extensively in endocrine, so I'm not going to cover it extensively now, but what I will say is just a refresher. If you have low blood pressure because you have low fluid or maybe a high volume of sodium that needs to be excreted, our body is going to do what it needs to convert angiotensin to angiotensin 1. That's occurring there at that renal level. Angiotensin is being released by the liver. Angiotensin converting enzymes are coming from the lungs. Let's remember that angiotensin converting enzyme. Remember we talked about ACE inhibitors in the first video. There you go. That's what that correlates with. Is going to convert that into angiotensin 2. And angiotensin 2 is going to do two things. A, cause the vessels to constrict, which alone will increase blood pressure because now we have an equal volume in a smaller space. But simultaneously, it's going to release aldosterone, which is causing us to reabsorb sodium, which is going to increase our blood volume because the water is going to follow the sodium. And if the sodium is going back into our system, so is the water. And that is going to cause an increase. Sorry, guys, I know I just drew a decrease after I said the word increase. That's going to cause an increase in our volume. So that's going to increase how much blood we have. And then that's going to increase, that's going to decrease the space for it to travel through. So that was how big it was before. Now it's only this big. So we're spitting all of this blood volume inside that little circle. And as a result, our blood pressure is going up. So that whole system directly involves the blood pressure. You covered it in endocrine. We covered it in respiratory a little bit when we talked about that ACE, and then we covered it in hypertension. So you've gotten it several times. That means you should be experts on that now. So the pathways of circulation. We've got two primary pathways. First is going to be the pulmonary pathway. Pulmonary pathway is from the time we leave that right ventricle going into the pulmonary arteries, into the lungs where that exchange of gas occurs. We pick up all that oxygen from the lungs that we need, and then we send it back into the left atrium by way of the pulmonary veins. So oxygenated blood is going to return. That's going to then move into the left ventricle to be pumped out to the body. Once it leaves that atrium, that left atrium, and goes into the left ventricle to pump out to the body, it has now become part of the systemic circulation. And that systemic circulation is encompassing everything else. That blood is leaving the heart. It's supplying all the vessels that go throughout the body, going up through the aortic arch, sending blood out to the head, brain, arms, chest, the heart itself, the muscle of the heart. And then you've got that aorta that comes out from the bottom of that arch, going through the abdomen and forking off the renal arteries and the femoral arteries, with some additional changes that go through there, supplying blood to everything below the heart. The only exception to those rules of systemic and pulmonary is going to be that hepatic portal of circulation. It's its own special little part where digestive organs, liver, spleen, those components are going to regulate and filter the blood independently there before joining back into circulation. That is about all we're going to say about that, because we're going to talk extensively about the hepatic portal when we get more into liver and spleen in 102. But just please know that it is an alternative route. So we talked briefly about aging. We're going to touch on that again. As we age, everything slows, and we know this. So the conduction cells are going to be less effective, and the conduction cells they're referring to is that cardiac electrical conduction, those components that allow the transmission of the electrical impulse from one place to another. Atherosclerosis is depositing of fats in the walls of the artery, so those walls are becoming clogged up with extra junk. We have a rise in our resting blood pressure over time due to changes in the vasculature. We have a decreased heart rate because, again, everything slows down. And then the vein valves become a little bit incompetent. They're not as likely to be able to work efficiently. They've worked for years and years and years, and they're getting tired. They work less efficiently to move blood from those lower extremities or those extremities in general back into that central space for return to the heart. So as a result of that, we have a combination of things like venous stasis ulcers, the blood stays down there in the bottom, fatigue, a stroke, or heart failure can result for the blood pressure increases causing stretching and damage to the muscle. That atherosclerosis or narrowing of those vessels due to plaque buildup is going to lead to a couple of things. A, that endothelium, which is that skating rink surface that's so smooth everything just slides by, is now covered by fat, which is sticky. So things begin to stick to it, putting us at risk for clot development. And if we do develop a clot, then if it breaks loose and goes flying around in our circulatory system, we end up with a heart attack, stroke, pulmonary embolism. And it can also reduce the amount of blood flow to other organs and to the heart, because as those vessels become narrower and narrower, a decreased amount of blood is moving through them to supply the heart and the other organs, meaning that they're not going to function as well because they're also going to have a decreased amount of oxygen if they have decreased blood supply. And then lastly, those changes in conduction cells give us dysrhythmias. The rhythm of the heart should be very consistent. It should have a P followed by a QRS complex ending with a T, or that repolarization phase. And that is not an option. If we have a dysrhythmia, that whole pattern changes, which can be extremely challenging to navigate when the patient is feeling those symptomologies from that change in rhythm. So one thing, let me go back one thing here. We talked yesterday a little bit about venous ulcers and arterial ulcers, and that was very brief, but I just want to make sure that as I replayed some of that discussion in my head last night, I thought maybe that wasn't as clear as it should have been. So if the artery is forcing blood down and the artery is working correct, but the veins are not and the valves are not working well and the blood can't escape, that extremity is going to be warm. It's going to be red because you're getting blood down there, but it's not getting back out. When the extremity is cool, lacks color, maybe has those really hard, thick nails, maybe some clubbing, a lot of that is going to be more venous because, or arterial, because the veins are taking the blood away, but the artery is damaged and not getting it there. So there's not nice warm blood to come to the area to make it warm or colorful. So that person with arterial insufficiency is going to have the blue, cold limb, and the patient with venous insufficiency is going to have the warm red or purple almost limb because there's so much red. So when I say red, if you were to tie a rubber band around your finger and it would get much darker, that's what we mean by purple, not that blue associated with the lack of oxygenation. So if that doesn't make sense or you need to talk about that further, please let me know. I played that conversation again in my head and I could see where there was some confusion, so I wanted to clarify that. Arterial insufficiency is going to leave a cold blue limb because no fresh blood is getting there. Venous insufficiency or venous stasis is going to lead to trapping in that new blood but nothing going out. So you are still going to have some decreased exchange of gases and things as it's not working like it should, but you'll have red and hot limb. So we can discuss that more if you have questions. Aging, we talked about that, the atherosclerosis or the fat and lipids that build up in there, the arteriosclerosis or the narrowing and hardening of those vessels, increases in blood pressure for those reasons as listed above. Valves don't work as well. The heart muscle has been used and abused over time, and it's getting a little stretched and floppy and weak, and it's just not as strong as it used to be, so it's going to be less efficient. And then those arrhythmias are common for the reasons we just discussed. So heart disease. Heart disease affects about 92 million adults. #1 cause of death in the United States, impacts more women than breast cancer. Red is typically the color associated with that. Healthy lifestyle changes like quitting smoking, exercising, reducing your fat consumption, maintaining a healthy blood pressure, blood sugar, and cholesterol level, and maintaining a healthy weight are all going to directly contribute to reducing your risk of cardiovascular disease. And here you have some websites and some information to go to get a little bit more information on specific impacts on different groups, women, African Americans, and about how you can make some changes in that environment. So when we're assessing our patient, the first thing we're going to do is obtain a health history, right? We're going to ask them some questions. So when we ask those questions, what are we looking for? #1, we're probably going to ask things about their medical history and their family history, right? Because their medical history and family history is going to give us an indicator of what they're likely to have. We're going to ask them about allergies. Do they have allergies to anything? We're going to talk about medications. Again, a lot of times people will maybe not be the best historian. They may not remember exactly what disease process or what events that they've had occur in their life, but a lot of times their medications will give us clues into their history. And then health promotion methods. So by health promotion methods, things we're asking is, you know, how many days a week do you exercise? Tell me about your diet. Asking some questions so we can see what they're already actively doing to improve their health. And then using that "What's Up" acronym, we're going to ask them about where is their pain, how does it feel, do you have any aggravating or alleviating factors, things like that. And a lot of times when we're assessing these people, it's not like they came in for this horrific chest pain and are having major issues. So you may not have a lot of details in that "What's Up" section, but these chronic conditions are leading to issues, and that's the reason we have to continue to evaluate them. Even if they're not necessarily causing pain or problems in that moment. So after that, we're going to begin our physical exam. First off, let's just look at the patient in general. How do they look? Are they huffing and puffing because they can't breathe? Are they swollen? Are they blue? Do they have club nails? Just get a general survey. What do we see that stands out as abnormal? Is their chest, you know, uneven? Do we have one side that's larger than the other? Or major scars that might indicate we've had surgery before? Things like that. So just get a quick overview. We want to get a set of vital signs. Let's assess for hypertension or hypotension. Maybe our patient's got a low blood pressure. And then we also want to obtain orthostatic vital signs to see exactly how well the heart and the blood vessels and our neurologic system and our cardiovascular system are working together to maintain that homeostasis or that baseline for that patient. And then a height and weight, which is going to give us an indication of a couple of things. A, their risk for some complications associated with their weight, and also opportunities for health promotion and education. And then gives an opportunity to then evaluate what changes we need to encourage for that patient to get them back on the right track. Okay, so we're going to look at our patient. We've got those basics and the general survey. So we're going to look at their oxygenation. We know this isn't a respiratory assessment, but we now know that the function of the lungs is entirely dependent on the heart to pump blood to them so that they can then exchange that gas for us. And if the heart is not getting it there because of damage to that pulmonary artery or not returning it to the heart from the lungs because of damage to that pulmonary vein, then we're going to have decreased oxygenation. And so we can assess that through taking a pulse oximeter reading, looking at their skin color, looking at the extremities. Do they have hair on them? Is their skin turgid? Are they dry? Is it good? What are the nails? How thick? Are they hard or are they nice and clean and see-through, kind of like we want? And then edema, is it present? Is it absent? Is it pitting? Is it non-pitting? Remember, if it's pitting, if you were to place your thumb over the bony prominence and push down, that it should leave an indentation of your finger to be considered pitting. Non-pitting would be that you feel that squish, knowing that there's fluid in there that's moving, but it doesn't leave an impression of your finger. And then no edema would be the absence of that squishing. And then color, red or blue, or normal for ethnicity is a safe way to describe that. Please remember that someone's ethnicity and the color of their skin does not mean that you don't have the ability to thoroughly evaluate their oxygenation and cardiovascular status through color. The palms of the hands, the soles of the feet, the nail beds, the gums, all of those areas still give you plenty of opportunity. The sclera and the conjunctiva of the eye, those all give you plenty of ample opportunity to evaluate perfusion. Jugular vein distension. You've got the video on JVD. Please watch that, refer to that. If you have questions, let me know. Capillary refill. We're looking for that to be typically less than 3 seconds. Some of your literature is going to tell you 2 seconds, but less than 3 seconds is considered appropriate. We're going to squeeze the nail, wait for the blood to kind of leave there, leaving a white place, let go of that nail bed, and then watch to see how long it takes to return to its baseline color. If that takes less than 2 seconds or less than 3 seconds, then we have adequate capillary refill, which has given me a good indication that I have arterial flow to that area as expected. Clubbing, we talked about yesterday. That's when we're going to take and put our fingers together, making that little space between them. You should be able to get the diamond. If you can't remember, does it give you the picture? If not, I'll show you real quick. So you're putting your fingers together like that. See how we can see through mine? It kind of makes that little diamond space you can see through to the paper. That indicates the absence of clubbing. If I did have clubbing, it would look more like that if they were held correctly. You might see a little dot or something, but that diamond would not exist because the angle here would be so much increased that you wouldn't be able to see that adequately. All right, so clubbing, make sure you evaluate for clubbing of the nails. Visual there of what clubbing is, and now you can see why you lose that little diamond is in that space. So continuing with the physical exam, we're going to palpate that point of maximum impulse. We talked a little bit about what that PMI is, and that's going to be associated with the point where you feel the greatest pressure or movement from the heart. Sometimes that's easy to feel on a person depending on their size and shape. Sometimes it's very difficult, so placing your hand over that point and then having the person lean forward or lay on their left side is going to make that a little bit easier to palpate and feel. We've already talked about temperature, but we'll talk about it again briefly. Is, you know, if a person has poor blood flow or poor exchange of blood, you may end up developing a change in temperature. The extremity may become cool, like the room environment is. Edema, we just talked about that, and putting pressure for 5 seconds over that bony area and assessing that. That's pitting edema there. One thing that I don't particularly love that our slide left off here that I think is really important is those peripheral pulses. We need to assess peripheral pulses in at least 4 areas, bilateral radial pulses and then bilateral pedal pulses, unless, of course, your person doesn't have a limb in that area. And then you're going to want to go to the closest palpable pulse to that. So say we have someone who's lost their leg below the knee, then we're going to go ahead and feel behind the knee for that popliteal pulse. If we don't have the option to do a pedal pulse. So whatever your closest option is to the amputation, you want to get as far away from the heart as you can and still feel a pulse. And you're going to grade those pulses, 0 being absent, 1 is weak, 2 is kind of normal, and 3 is bounding. And a lot of time bounding means like something you actually see. That's not just something small. You may be able to see that, or you're just going to feel like that boom as it's hitting your fingers as you're measuring there. Also, we're comparing that to the heart. So if I'm listening to the heart and I'm auscultating a heart rate of 70 beats per minute, but I'm only palpating 50 beats per minute in that radial artery, then we have a problem. Why is the blood not moving through the extremities at the same rate as I could hear the heart pumping? And so that's something that at that point we need to evaluate and notify notify the healthcare teammates so that they can evaluate that. Auscultation, we're listening for heart sounds. S1, S2, those are the normal sounds that we talked about in the beginning, and this kind of gives you that visual again here. You've got that S1 here and here. As the valves are closing, you see the ventricle begins to contract, and as that ventricle squeezes in, it puts pressure here, which closes that valve so that the blood can't go backwards into the atrium, and instead it pushes it out through this open valve here, and that gives you your S1 sound. When that cycle completes, that relaxes, and then in turn, the S1 valves, or the tricuspid and the mitral valve, open to allow blood to move from the atria into the ventricle through that squeezing. Then this S2 valve closes so that that doesn't push blood out at the inappropriate time. And when you hear that close, that's that second heart sound. What that relates to on this EKG, which we haven't gone over much, is this QRS, that squeezing of the ventricle, and then T, and then that's your relaxation or repolarization, allowing the heart to kind of relax and refill portion up here, which is coming out through that S2. So you're not going to be able to recognize these EKG changes yet. We haven't had enough opportunity to really fully evaluate EKGs, but identifying those sounds. Occasionally, you are going to hear additional sounds like an S3 or an S4. You may not be able to differentiate between which one's a 3, which one's a 4, things like that, but that's an alteration from that lub-dub 1-2 sound that you hear, and something that we need to identify as abnormal. Murmurs, we talked briefly about murmurs and the fact that those valves should be closing completely. If those are not closing completely, and we're allowing some blood flow to move backwards or in the wrong direction through the valves, you may hear like a turbulent sound, a swooshing sound, an abnormal sound. And though you may not necessarily immediately hear it and go, oh, they have a murmur and it's a grade 1, 2, 3, 4, 5, you will identify that there's an abnormal sound, and it's swishing, and it may be very loud or it may be very mild, but identifying that you have that is the most important factor. And then that pericardial friction rub, we talked in the beginning about the heart lives inside a 3-layer sac separated by serous fluid that allows it to move smoothly across each other. If for some reason that fluid level changes, if the heart stretches and is touching forcefully against that outer, that layer of that fibrous layer of the heart, that pericardial sac, or for some reason there's bleeding or damage inside of there, you may not have that frequent soft movement like you would expect with that serous lining. And so you end up with a rubbing sound as if you're rubbing your hands together. And that's going to be called the pericardial friction rub. Again, sometimes if you can't exactly identify those sounds, placing that stethoscope over each valve response area. So we'll look at that just a little bit to get a better understanding of where that is. It's on page 351. I'll show that to you in just a moment. You can hear each valve, and that'll help you better identify those S1 and S2 so that you can hear them together. And then also you can have that person lean forward a little bit so that you can hear a little bit better if you need to. So let me switch over to the book for just a minute for you guys to see that. All right, so we talked about the tricuspid valve being the kind of the first in the system, right? But maybe not necessarily be the first one that you hear. So the goal typically is to start just below the second clavicle and on either side of the sternum, and you're going to hear that aortic valve open and close, and then hear that pulmonic open and close, which is going to be S2. That should be your dub sound. After that, we're going to hear the tricuspid valve and the mitral valve. These are the locations where you're going to hear those sounds best, and that's going to be your lub or your S1. That'll be the first heart sound, and these will be your second heart sounds. So listening in each location is going to give us a little bit better depiction of the sound in that area. All right. So we talked about that. Diagnostic tests. We are not obviously going to be performing all of these tests in the clinical setting, nor will you perform all of these in your general nursing care. It really is going to be dependent on your area of expertise and that you're working to kind of make that final determination. But we're going to talk briefly about the arterial stiffness index. It's doing exactly what it says, measuring the arteriosclerosis of the vessels and how hard or stiff that artery is or narrowed that artery is, so we can get a better idea of the blood flow through there. Chest x-rays basically going to tell us about the size of the heart. Doesn't give us a ton of detail. That CT scan, I'm going to look at plaque in the coronary arteries, especially those arteries that are supplying blood to the heart muscle itself, give us an indicator of their health. That MRI I talked to you, and that MRA I talked to you about that yesterday with a little bit of enthusiasm, because it does this super cool thing of making like a 3D image, so we can look at the heart in multiple planes, which is really nice, and it also allows us to see the vessels pretty good. That EKG or ECG, that's what we use very, very commonly in the hospital setting. That's focusing on the electrophysiology of the heart and those electrical impulses. Now, that being said, trying to make this as basic as I can, but the fibers of the heart should determine, those Purkinje fibers take a specified amount of time to travel from one end to the other. If they take too long to travel, we can tell something about the muscle itself or the heart function itself by, is it stretched and it has to travel a longer distance, or is there an area of the heart that's not working as well, that's forcing the conduction to kind of go around a different pathway. And so it does give us a little bit of a picture about the anatomical aspects of the heart, but for the most part, we're looking at the electrophysiology there. Typically in the hospital, you're going to see 3 or 5 lead EKGs. Unless we have a chest pain issue or some kind of concern, you're going to see 12 leads. 15 and 18 leads are reserved primarily for cardiologists. That signal averaged ECG, that's going to be evaluating the heart over time, usually about 20 minutes, and we're looking to see how many low amplitude or weakened strength impulses we have that put us at a risk for a ventricular arrhythmia or a dysrhythmia that can be deadly. And then the ambulatory monitoring, or that Holter monitor, is something that the patient can wear at home and going to correlate their symptoms with the time on the recording of the cardiac event. So say a person is walking around at home and they feel short of breath and lightheaded, and they write down that they felt short of breath, lightheaded, and their heart was just beating out of their chest at 12:02, and then they go over to the doctors after they evaluate the monitor, and they see at 12:02 the patient had a run of premature ventricular contractions, or PVCs, meaning the bottom of the heart beat too fast, and they can see why the person is feeling that and help transfer that into their care about how they're going to manage it. So that ambulatory ECG monitor allows us to watch the cardiac tracing over an extended period of time remotely. Echocardiogram, that's the ultrasound of the heart. It allows us to look at the heart structure, shape, size, how it's positioned in the chest, especially after trauma. How well does it move? Is there blood flow in the correct direction, or are the valves not closing completely, and are we seeing blood backing up in there or regurgitating into the abnormal spaces from where it should be? It's an excellent, excellent tool, and one of my favorite things to watch, especially if it is a TEE or transesophageal echocardiogram. That is when we're going to put a tube down the patient's esophagus or throat so that we can get a better picture of the heart with less interference from external organs, adipose tissue, bones, things like that. We have a lot better vision, with that TEE, but it's a little bit invasive, so not our primary choice. And then we have strain and stress echoes, which are where we're watching the heart in the same conditions, but after we cause stress to the heart or strain to the heart to evaluate how it's responding. So for that TEE, we're going to give some kind of anesthesia to the patient, give something that's going to numb the throat to prevent that gag reflex from occurring the entire time of the procedure. We're going to place that probe down there. It gives us better pictures, as I said. And we're going to keep the patient NPO until the gag reflex returns. Priority intervention there to make sure that we don't have a patient who ends up with aspiration pneumonia from an evaluation for their echocardiogram. Please make sure that you evaluate beforehand so that you have a baseline of care, and we will go from that. Exercise stress test. That's pretty straightforward. We're going to put our patients on the treadmill and stress them out a little bit and see what the heart does in response. Priority interventions right now we're going to be on how are you going to educate your patient to prepare for that test? What would you do if something goes wrong during that test? What are your emergency management responses? And then how do we evaluate kind of the changes that occurred during that to help develop the plan? And then the same thing for that peripheral vascular stress test. The patient's going to walk on the treadmill. We're going to measure their pulse. And then intermittently throughout the procedure. And then we're also going to assess their legs. Are they having pain or changes during that time? And that's going to let us know that maybe the vascular system isn't responding as well as we would like to that walking. I told you we are not spending time on that nuclear testing because that is not something that you or I are going to have the opportunity to do. That's a specialized area. But that's just a way that we can do some really specialized imaging of the heart, especially after a heart attack, based on the specific injection that's provided, those radioisotopes that we're watching on that camera. And it's going to give us a better idea of if there is muscle damage, blood flow in that area. And I hope that we all get to participate in that at some point, but we're not going to be doing that during clinical at this time. So the table tilt test, the tilt table test, that's kind of like we talked about with having our patients stand slowly. We want them to sit and dangle. In essence, we are doing the opposite of that on this table and seeing how the patient responds in a safer and controlled environment. Ultrasounds, Doppler ultrasounds. As blood flows through an artery, we may not always be able to feel that depending on where it is, but it still comes from the heart in an undulating pattern or creating waves, if you will, as it moves through the vasculature. And so as it does move through the vasculature, as it crosses specific areas, you should be able to auscultate that through the use of a Doppler. It will actually record that sound wave and produces a sound that you can identify. So you'll hear as the blood is moving through that area if it is working efficiently. So before you send your patient down for any of these lovely procedures, we want to make sure that we know that we have the right patient, just like we do our 6 rites of med administration. Please do your rites before you send a patient down for a procedure. I told you if for some reason you're the person who receives the call that says that you have an abnormal finding and you don't report it, and your patient has an injury as a result, that's 100% on you. That's your fault. So please do as they suggest here and get important test results to the right staff or right person at the right time. Blood studies. These are our labs that we talked about. I told you biomarkers is not a commonly used word, that more commonly you're going to hear enzymes, and that's going to be done serial. You know, I love me some Ed Kemper, so I'm telling you again, serial not meaning something we eat, but serial as in repetitive serial killers, serial enzymes. We're doing them a bunch of times. So typically they're going to be done every 6 to 8 hours for a minimum of 3 times. The reason for that is we're wanting to see peak, onset peak, and then we want to see a gradual return. So we may not follow it all the way back to baseline, but once we see that the enzyme has gone up, it's gotten to a certain height, and then after that third draw at 18 hours or 12 hours, depending on where you are, that's going back down, then we know that no additional injury is occurring. And if it continues to rise, then we know that there is additional injury to the muscle that this patient is suffering that we need to be performing interventions on. So that being said, that CK is going to be specific to muscle, but not necessarily specific to which muscle unless you add that MB at the end of it, and that CKMB is going to be more directly related to that myocardial function. So that's going to give us a little bit better idea if the patient is suffering with damage to the heart and muscle. We're going to have a 4 to 6 hour onset time with a peak at 12 to 18 hours. So from the time somebody maybe reports chest pain to the time you actually see a rise in their CKMB is probably going to be about 4 to 5 hours. And it will peak in that 12 to 18 hour mark. The myoglobin, it is not specific to the heart at all, but it's going to respond really quickly. So within an hour, we're going to see that something has occurred. So if someone comes in for chest pain, we draw that myoglobin, and in 2 hours, we see absolutely no elevation, and that's probably going to give us an indicator that the pain was not necessarily a result of muscle damage, but it doesn't specify which muscle. So it's a very generic test, but it works rapidly. And then most importantly, the troponin. Troponin is 100% cardiac muscle. It's going to be the most accurate test for cardiac damage, but it also takes a little bit of time. It's going to take 4 to 6 hours to begin to increase, and it's not going to peak for 10 to 24 hours. And so if we waited for troponins in that 10 to 24 hour range, we'd have a problem because muscle damage could be continuing to occur while we were waiting for those results. And that's the reason we use that CK and that myoglobin. What do we have? Homocysteine. Homocysteine level we talked about is going to give us a little bit of information about the damage to the lining of the heart or the lining of the vessels, that endothelium. If those are elevated and that lining damage has occurred, then we have increased risk of developing clots. And we can try to treat that a little bit with folic acid and some of those B vitamins. That CRP or C-reactive protein, that's going to give us a little bit of an indication the patient is more likely to have an MI or a heart attack or some kind of inflammatory response. And this is going to help us educate our patient to reduce those cardiac risk factors. It's not necessarily going to be a retroactive response, but our CRP or C-reactive protein is going to be more of a proactive lab evaluation. Lipids, we're looking at cholesterol, triglycerides, phospholipids, HDL, LDL. Please take a little bit more time to review that in detail on page 354 of your textbook, but we need to talk about educating our patients. If we're going to draw a lipid panel to evaluate that, the last thing we need them to do is eat 7 boiled eggs right before they come in, or even a couple of hours before they come in, because we're going to have falsely elevated results. So we need to kind of evaluate the patient's routine diet, have them fast for 8 to 12 hours beforehand so that we can get an accurate level of what's actually happening inside their body and their bloodstream, as opposed to just what's going on with their diet. So we'll evaluate that to determine how much plaque buildup and how much buildup we have in the arteries inhibiting blood flow. And that's going to impact our liver and the ability to clear out some of those additional triglycerides and fats. So we may need to be put on a medication to manage that, and those medications are usually going to end in statin, S-T-A-T-I-N. Those are a lot of times those cholesterol medications that were put on for preventative treatment for our heart. And then lastly, we've got the magnesium there. We're not going to focus on magnesium. We talked about electrolytes significantly. We know that magnesium is extremely important in electrophysiology of the heart, as well as potassium. So we're not going to talk about that any more than we have. And if you have additional questions on it, please let me know. The cardiac cath procedure, that's an invasive procedure that actually involves us poking a hole in someone's artery. putting up a catheter through that area that will then allow us to inject dye in through those vessels. And then on the screen here, you can see this machine. Oh, if I get a color, sorry. This machine is basically like the video camera recorder. It is viewing the dye and the blood and looking at the difference in that, sending it through here. It comes out as a visual on this machine that your surgeon is watching. And so if we're going along and this is, you know, the vessel running on the side of the heart, and then all of a sudden it gets like that and then comes back out, well, then we know that in this point right here, we've got a significant narrowing. So from here, we were at 100% open, and well, that's maybe like a third of that. So maybe that's a 70 to 80% blockage of that vessel. And so if we've got 70 to 80% of that vessel occluded, that means that this distal portion, or the portion following the occlusion, is only getting about 20% of the blood flow that would be ideal for that area. So we're not going to have as well of a functioning muscle following that. And then also, it doesn't take something very big to clot off this area. So right now we have a reasonable amount of space for something to come through. But if all of a sudden we're going long and we have this big old piece of clot or fat or plaque that breaks off, and it's traveling along, just beam bopping along with no problem, but then it gets to this area that's narrow, now it's occluded it, and so everything below that point is now blocked off from oxygen and blood supply and is at risk for dying. So what we're actually looking at with that cardiac cath is that specific space right there. We're looking to see how wide or narrow or how the flow is through each individual vessel, so that we know if we need to be doing something to intervene and fix that, or if the heart is likely to have good blood supply and going to be okay. And so with that being said, because we do have to access that through an arterial site, the patient's going to need to have some special care post-surgical pressure dressings to make sure that we don't have incidences of bleeding. And if we apply a pressure dressing to any kind of arterial site, or any site really for that matter, we can potentially cut off blood supply to anything distal. And so it's of extreme importance that we're assessing cap refill, temperature, color, pulses, anything that you would want to assess to verify that we have not eliminated blood supply to that area and put the patient in a position to potentially lose a limb or cause permanent damage. Jessica mentioned yesterday the sensation, verifying that they don't have numbness or tingling there. So please, please, please make sure that you monitor the site for bleeding, monitor vital signs, monitor the pulses, cap refill, all of those things, and please let me know if you have questions there. Therapeutic interventions, primarily we want to get our patients to make lifestyle changes instead of just trying to medicate them through it. Exercise, diet, healthy weight, healthy foods that are not going to be high in that cholesterol or that high fat content to develop around the heart. Send the support groups to encourage those dietary and lifestyle changes, and trying to get that person on the right track to make health promotion choices without medical intervention. Sometimes that works, sometimes that doesn't. In the case that that doesn't work, we're going to need some other things, and sometimes even if it does work, we may still need additional support to keep that person at baseline. And so we may need anti-embolism devices like TED hose, which we all know are a bear to put on, but that's going to really improve that blood flow. The arteries are working, but the veins aren't. That's going to keep pressure on there, helping to return that blood into the circulatory system, reducing edema, reducing the risk of developing venous stasis, ulcers, etc. Intermittent pneumatic compression and SCD, sequential compression devices. Those are very, very, very similar products. That just means that it comes on and goes off either in sequence or intermittently. Pressure is applied and released, similar to that peristalsis, if you will. which is the valvular movement helping to return blood to the heart. And then oxygen therapy as appropriate. If a patient has chest pain or if a patient is suffering with a cardiac event, what we want to do is make sure that the part of the heart or the system that is not receiving enough blood due to the damage is still being perfused with as much oxygen as it can so that the tissue doesn't die until we're able to return the blood supply to baseline. So we may hyperoxygenate our patient mildly in an attempt to make sure that the hemoglobin carrying capacity increases and that we're getting enough oxygen to that area to make sure that we keep that muscle or that tissue alive until we can restore blood flow. So like, let's see, let me get through this and I'll show you one more thing or two here. So therapeutic interventions, again, medication management as appropriate, medicines to control blood pressure. If the heart rhythm is out of rhythm, we need to fix that. Something for chest pain is an anti-anginal. Anticoagulants is going to prevent those blood clots. Thrombolytics are actually going to bust up the clots, and then vasodilators are going to increase the size of the vessels to allow improved blood flow. We talked specifically about certain classes of medication in our hypertension discussion in the video before this one. Please refer to that. And then some of these other components like the antiarrhythmics, we will talk about more specifically associated with chapters 23, 24, 25, and 26 when it comes to the electrophysiology of the heart as well as MI. So surgery, we talked about bypass a little bit. We're not going to go back through that today. You can always refer to that image there on 358 about the bypass machine, but the short version is we have to do exact opposite of what we're used to doing, which is to hold the coagulation modifiers for our patient going down for the bypass surgery. They will actually need those coagulation modifiers to get their blood thin enough that it will not clot during the bypass while the blood is circulating outside of their body. It's fairly general procedure for cardiac surgery because we need to have a space where we can A, see to work on, and B, reduce the loss of blood through that intervention, because if the heart's still pumping it out, it's not going to improve anything for anybody. So one other image I wanted to share with you about that adipose tissue. I'm going to show you a healthy heart real quick. All right, so that's a healthy heart, right? Somebody who's eating a nice normal diet. Little bit of septal wall changes here, right? But you can see the blood vessels coming down, supplying the heart. You can see the large vessels coming out of the heart. Now let's look at this one. That yellow, let's see if I can get the color to do a little better for you. Color's not great, but all of this yellow, that's fat. All of this yellow stuff is fat. You see a little bit of muscle there and a little bit there and a little bit there. Now let's go to me telling you about this sac that contains the heart, and now all of a sudden it's filled up with all this extra fat. Is the heart compliant? Probably not. Is it able to move the way it needs to? Probably not. You can see your large vessels that are where blood is coming out. Even the vessels are thick and stiffened. So that's going to make a significant impact there. So I think that covers most of the stuff that we talked about. It gives reasonable detail. I know yesterday's lecture was a little bit better, but we don't have 6 hours to redo the entire thing. So I've condensed it the best I can while still trying to hit the most important parts. I'm sure there's something significant that you may have questions on, and I will be happy to discuss any of it or answer any of it with you. You just have to notify me that that needs to occur, and I will be happy to help you. Please use the discussion forum to post questions so that I can answer you as a group if you have something that you need additional information on. If the visuals aren't quite where they need to be and I need to work on that, just let me know and I will try to do what I can to get that for you. If you need anything, just tell me. Thanks, guys.